Hello, everybody. So thanks so much for joining us today. So good morning to those on the Pacific coast and afternoon, and those of us in the middle, I think we're at lunchtime-ish. So thanks so much for joining today. I'm Andy Dwyer with the University of Colorado Cancer Center School of Public Health, and I'm the chair of the National Navigation Roundtable supported by the American Cancer Society. So I'm super excited that we are in a series of webinars talking about sustainability of patient navigation. And in this specific webinar, talking about policy initiatives related to sustaining navigation. And it's quite timely, given that we're having such great opportunity in terms of really looking at policy initiatives from the state, national, and federal level, regional level, really thinking about supporting navigation. So I'm super excited to have all of our panelists joining today. Really thank you again to our sponsors and to everyone who's supported this work in the American Cancer Society, who's been making a lot of this initiative move forward with the great work and the fuel from so many experts in the field, but we couldn't do it without ACS's support and work, and want to thank all of you. So just as a quick reminder, follow along, post frequent, early and often on X, at NNRT News, also LinkedIn, Facebook, a lot of opportunity to share information because I know there's a lot of amazing things happening that folks are very much interested in. And I must say that I am going to make Michelle happy, Michelle Chappell, who's one of our awesome team members in NNRT, and asking at the outset that as we provide the link for the poll today to provide evaluation and feedback, that please send as much information related to the format, what you hope to learn in the future, how we did today, and any questions that might be coming up for you. So with that, we'll go ahead and go to the next slide. And I think lovely Michelle will have a few words for us about the technology and the Zoom best practices. So Michelle, take it away.
Great. Thank you, Andy. And just to let everybody know that today's webinar is being recorded. We are also going to put forward the recording, and the slide deck will be made available also on the website by December the 11th, which will be on the NNRT website under events. We will also be using Slido today, so please make sure that you have your smartphone available and have it set in your camera mode. We do have 2 polling questions that we would like to have your participation in. You will use the Slido. It's going to be the same QR code that is currently on the screen, or you can go to slido.com and we will be sharing the Slido link with you in the chat. Your mics will be muted today during the video webinar presentation. That way we have, we won't have any background noise or feedback through the lines. We do ask that if you have specific questions to any of our panelists, that you please type those into the question and answer box, which will be at the bottom of your screen. If you have any direct communications that you would like to do, you could also put that in the chat. But again, for questions and answers, we do ask for that to go into questions and answers. Andy, I'm going to pass it back over to you.
Okay, thank you, Michelle. And I just want to say I'm super excited as I see the number of people joining today, now over 140 individuals. So, and again, another shout out to the sponsors. This project and really a lot of the under support for the work is by Novocure, Genentech, Sanofi, Daiichi Sankyo, and Bristol Myers Squibb. So thank you so many of our industry partners for really helping support the work of patient navigation and really allowing the opportunity to move forward this work as we really think about the constructs of sustainability. So next slide real quick, Michelle. And I also love the number of people who are putting in the chat who you are. So who you are, your organization, and what role you play. So loving to see all of the information. So if you are so inclined to share a little bit about who you are and where you're from in the chat, that would be super helpful. So today, as noted, we are going to be spending some time talking about the policy work, but specifically, we're really going to be talking about who are Medicare, who are Medicaid, who are private insurers as it relates to the orientation of who they serve. Then also ultimately, what does it mean in terms of the patient navigation orientation? And what do we know about who's doing what for the communities that they're providing coverage care for, and particularly around the CMS ruling and really delving into that. We're really going to have a chance to hear from the American Cancer Society and the Cancer Action Network and what's on the horizon. And I'll share a little bit about also our policy perspective and the leaders of one of our task groups that are really going to be sharing that perspective and really your call to action and opportunity. And so I think Katie, who is one of our esteemed panelists, next slide, who's going to be joining, made a reminder to all of us today that there is a lot of amazing things that are going to be happening as it relates to the development of the CMS work and also things that are starting to develop for the insured private and public insurance space. So we're giving a real-time setting today of what's happening, but knowing that this is going to be an evolving topic and really something that we're going to continue linkages with all of you to think about how do we grow, support, and continue to advocate and educate about navigation. So to that extent, a reminder that the National Navigation Roundtable, we are really committed to high quality cancer care for all through the evidence-based patient navigation approaches. Our vision is a collaboration that advances navigation efforts to eliminate barriers to care, increase quality care, reduce disparities to improve health outcomes, and fostering ongoing health equity throughout the continuum. And as a quick reminder that really our focus over the next 5 years is really to support the creation of a sustainable model for oncology care to achieve health equity across the cancer continuum. So I just want to remind everyone, we really are about the big tent. We are really thinking about all people in all community, patients really being the end user and our customer, and really the navigators who we support and the role and function of navigation supporting that sustainability. So next slide. And I must say that it's kind of fun because every time somebody writes who they are and their name, it pops up on my screen. So I'm just going to move us over a little bit so I can see my slides here, but keep it coming because it's super fun seeing everyone. And I think now we're at over 160 people joining today. So amazing attendance. I want to bring your attention to some great things that have been ultimately achieved and some of the great products that we have through NNRT. And I know Christina, who's the director of our NNRT, Jennifer, one of our co-chairs, and Linda Fleischer, Michelle, and myself have really spent some time in thinking about how we're talking about sustainability with our larger membership as well as our steering committee members. And just as a reminder that we are thinking about sustainability as it relates to what you're going to hear today from that reimbursement, the way to pay, fair, equitable wages, but we're really in terms of thinking about garnering that sort of support for the workforce. We're thinking about evaluation, communication strategies, champions. How are we really showing our impact in the world? How are we looking at internal, external communication champions to do this work? And to that extent, we're really building a cadre of resources that really talk about that policy. So our policy briefs and modules created by our policy task group, ultimately looking at the workshops and all that we have and related to the evidence-based in CA, in cancer, in our supplement that we've recently produced over the last couple of years, thinking about the evidence and ultimately talking about that evidence and looking at what are the areas that are still ripe for showing evidence as it relates to navigation. But moreover, what are we thinking about that dissemination and implementation? We have products and resources from AONN around those metrics and oncology navigation standards, really thinking about that role and really thinking about the professionalization of standard as it relates to navigators who are professional navigators, non-clinical, as well as those who are social workers, nurses, and the resources and tools to really support the entire workforce. And thinking about that thought leadership and engaging all of you as we move forward, talking things about the community guide, how that makes impact for our work, and of course this call to action series also being a product as well. So moving to the next slide, I just want to remind everybody that we have a lot of tools and resources at your disposal. Use them for implementation in the field, use them for the management, use them to educate. That's what they're for, our audience membership. So with that, Michelle, I know that we gave some instructions about Slido. Michelle, do you want to share a little bit about the poll right now as we're getting votes already coming in?
So yes, you can use the QR code with your smartphone and your camera, or you can go to the website slido.com and then type in 3025645 and it will populate in live time here. So appreciate
awesome.
Everybody that's participating.
Okay, great. And as I noted today, we are going to be spending a good amount of time talking about the CMS codes and ultimately what we are considering for the principal illness navigation work. So we want to really know, at baseline, what you and your organization are planning to incorporate for the CMS codes based on the navigation work that CMS is now helping endorse and support. So coming in about, I'm not sure, some yeses about a quarter, I have no clue about 20%, and no, just over 5%. So go ahead and keep those coming in. I know that we're getting polling results, and this is an active poll. So if you're just joining in, there's a Slido information about how to join in for the polls. And Michelle, I think we're ready to go to the next one, unless you want to leave this open for just a little bit further. Okay. Very good. So I am delighted to introduce our policy task group leadership, who are going to be leading out the call today. I think this group of women have a phenomenal grasp with a lot of different vantage points, but have been amazing leaders in terms of thinking about the work and the policy at large as it relates to navigation. But it's particularly as we start to unpack what's happening with the CMS ruling, opportunities for Medicaid at the state level, and even what's may or may not be happening with private insurance, but maybe some projected ideas about what may be happening in the future. There couldn't be three better leaders. Dr. Elizabeth Franklin, who heads the U.S. Public Affairs for Patient Advocacy Oncology from Sanofi. Dr. Katie Garfield is Director of Whole Person Care, a clinical instructor at Health Law and Policy, Center for Health Law and Policy and Innovation at Harvard Law School, and Gladys Arias, who is also joining us from ACS CAN, who's the Principal for Health Equity Policy and Analysis for the legislative team. And again, I got a lot of people showing up, showing me who you are. That sounds great. And so with that, Gladys, I don't think I forgot one of your titles. But again, I think it's amazing that we have people from academic centers, those of us who are part of our industry partners, as well as our legislative and policy gurus out of ACS and ACS CAN joining. So I'm going to go ahead and punt. And I think, Elizabeth, you are first up to share some of the perspective as it relates to what we're talking in terms of public-private insurance and some of our opportunities for policy moving ahead. So Dr. Franklin, I'll turn it over to you.
Perfect, Andy. Thank you so much. And thank you to all of the attendees. It is so much fun to see friends and incredible navigators in the chat. I think this is going to be a really awesome webinar, mostly not because of me, because I'm about to, I'm going to provide the more boring information of the presentation, but my colleagues, Katie and Gladys, are going to provide some really, really important updates. So I do need to set the tone though, right? I want to talk about the foundation for this. So we know that the CMS rule has been released, has been formalized, but we realize as we are having this conversation that there needs to be some base level information. So bear with me. I know many of you will be completely familiar with this information, but we did want to make sure that we go over it because we know that there will be maybe new navigators or folks who aren't as familiar. So going to quickly go over basic information about insurance, about Medicare, Medicaid, the different programs, and then what this rule applies to. And then I will turn it over to the much more riveting content from my task group co-chairs. So again, thank you everybody for joining, and I will jump right in. So again, want to level set the difference between public insurance, private insurance, and really where this rule applies, which is going to sit specifically in the Medicare space. So I'm going to talk a little bit more about Medicare. I also will talk about Medicaid. And I'm sure there'll be questions on Medicaid. We could do an entire webinar about this. So we're going to give you basic information, but of course, happy to take questions or follow up with you afterwards. So public insurance programs are run typically by the government. So Medicare, Medicaid, the Children's Health Insurance Program, veterans coverage, state-specific plans, and the Indian Health Service. Again, today we're really going to be focused on Medicare. So I will talk about what that looks like. And Michelle, next slide, please. So what are the Centers for Medicare and Medicaid Services? So we're going to reference CMS a lot today, and CMS is simply the federal agency that provides health coverage to more than 160 million people through all of those programs that I just talked about. And again, we will be focused on Medicare. CMS works in partnership with the entire healthcare community to improve quality, equity, and outcomes in the healthcare system. On each of my slides at the bottom right corner, you're going to find some very basic links where you can go and do some more research on these programs if you're interested. These are government links, so they're vetted. It's information about these programs. So encourage you to visit those links, and we will make sure that we send them to you after the presentation as well. Next slide, please. Okay, so Medicare, we're focusing squarely in the Medicare space for this rule as of today. So Medicare is the federal health insurance program for people who are over 65 years of age, certain younger people with disabilities, or people with end-stage renal disease. So again, Medicare covers those three buckets of individuals. And as many of you are very familiar with, because you work in oncology, so you probably are most familiar with Part B, but of course, A and D, there are different parts to Medicare. There is Part A, which is hospital insurance, Part B, which is medical insurance. And the reason that I bring that up is because oftentimes in-office infusions like chemotherapy or other cancer treatments are going to fall under Part B, but not always, right? There could be oral medications or other pieces that fall under Part D. C includes your Medicare Advantage plans, and D is your prescription drug coverage. So again, just a basic level set for what Medicare is, what it looks like, and what it covers. Next slide, please. Medicaid, and this is the reason that we wanted to provide this foundation is because we've gotten a ton of questions about Medicaid, and that makes a lot of sense because many of the patients being served by navigators across the country are covered by Medicaid, which is a joint federal and state program that helps to cover medical costs for some people with limited income and resources. And as you know, with Medicaid state expansion under the Affordable Care Act, we saw many more people covered by Medicaid. So this is an important piece to understand in terms of the various different ways people receive health insurance. Under Medicaid, we often think of this as a program that's funded by the state, but as you can see, the federal government has general rules that the state must follow. Through the ACA, there was funding from federal funding that goes to Medicaid, but each state runs its own program. So we encourage you to go to medicaid.gov to learn more about your program. Again, I am confident that many, if not all of you, are very familiar with the Medicaid rules in your state. You have to be to do this job, I know. But if you have questions, thoughts, please make sure that you're looking at Medicaid specifically for your state, or in my case, the District of Columbia. Next slide, please. So the health insurance marketplace, this is a service run by the federal government that helps people, families, and small businesses. This is where individuals are going on to healthcare.gov to seek their health insurance, right? So this was created through the passage of the Affordable Care Act. Again, folks are very familiar with this. Some states run their own marketplaces, but still, if you go to healthcare.gov and you navigate to the state that you're in, if you're looking for health insurance coverage, if you're assisting someone with health insurance coverage, it's still going to, in those states that run their own marketplaces, shift you out to those state plans. So again, this does not necessarily relate to the rule that we are discussing today, but we thought it was important to level set to help people really understand what the different programs are. Next slide, Michelle. Okay, so that's public insurance. Then we have private insurance. So it's insurance coverage run by a health plan provided through an employer or union, purchased by an individual from a private health insurance company, or coverage through TRICARE. So this is typically what we talk about when we say employment-based insurance. So I work for Sanofi. My insurance is covered through my company, and therefore it is private insurance. You can also directly purchase insurance if you wish, and then TRICARE, of course, is for active duty military. So we have public insurance, which is where we're sitting with this presentation today, and then also private insurance. And I'm confident that one of the questions that will come will be, what about Medicaid? What about private insurance? And we will make sure to address that by the end of the presentation. Next slide, please. Okay, so what does rulemaking mean? We are sitting here today talking about this because CMS released a rule that addresses coding for reimbursement for navigation services. So it was through the physician fee schedule. And rulemaking is simply the policy-making process for executive and independent agencies like CMS and other agencies of the federal government. And they use the process to develop and issue rules. So there are some rules that are set on an annual basis, like the physician fee schedule. So the origins of the rule are where it comes from. CMS has the authority to set the physician fee schedule, which helps to determine how providers are reimbursed on an annual basis. So this happens every year. So again, as we talk about this today, keep in mind that this is going to occur every year. Navigation may not be addressed every year, but the possibility to make changes and to make improvements or any sort of updates is possible on an annual basis. So the origins of the rule is put out, the notice of proposed rulemaking. So that's when you first learn that a rule is going to be laid out in the language that is laid out in the rule. So many of you were involved with NNRT, ACS CAN, AONN, AOSW, many organizations that actually commented on the rule. And that was when the notice of proposed rulemaking came out and you were able to provide feedback, because it's always open for a certain period of time. And then, of course, the final rule stage, when the rule is published and it becomes part of our healthcare ecosystem. And in this case, it will go into effect January 1st, which again, we're gonna discuss a bit more. And I think we're ready for the next slide, Michelle. And I knew that was either my last or second to last. So now on to the fun stuff. And I will turn this over. Thank you, everyone. Katie, I will let you go ahead.
Excellent. Thank you, Elizabeth. I think that provided some really important context for the rest of our conversation today. So let's go to the next slide. Okay. As you just heard, and as I think a lot of you have been aware over the last couple of months, we have seen this really important new rulemaking. Again, that's the creation of new federal regulations from the Centers for Medicare and Medicaid Services that will impact patient payment for patient navigation services moving forward. And again, we're looking at one particular public health insurance program, Medicare. So as a reminder, as you just heard, Medicare is our public health insurance program serving individuals 65 and over, individuals with disabilities, and individuals living with end-stage renal disease. And everything that I'm going to say is all about payment in the Medicare program. I'll just note that you'll hear a bit more from Gladys, who will speak after me, that there is also some momentum around patient navigation in other parts of the insurance landscape that you just heard about. So stay tuned for that. But for now, just keep yourself in that Medicare box. We're talking about Medicare enrollees. So what is this important new rulemaking that occurred? As you heard, this rulemaking is part of an update to what's called the Medicare Physician Fee Schedule. The Medicare Physician Fee Schedule is essentially a document that describes how CMS pays physicians and other enrolled healthcare providers for services provided under Medicare Part B. And again, that's sort of the section of the Medicare program that largely focuses on outpatient services. The Physician Fee Schedule lists more than 10,000 unique service codes. And these codes are essentially a shorthand way of describing specific services that physicians and non-physician practitioners can bill for in the Medicare program. The Physician Fee Schedule also outlines the amount that CMS will pay for these services. Though to do so, it uses a system of what are called RVUs, or relative value units, which can be used to essentially calculate the rates specific to the place that you're operating. And as we heard, each year CMS uses rulemaking to update this list. So that means each year CMS has an opportunity to add new services to the list, allowing new coverage like we'll talk about today, or alter key points about existing services. Next slide. Excitingly, this year's update to the Physician Fee Schedule includes several changes relevant to patient navigation, including the creation of new billing codes that can assist in reimbursing and hopefully sustaining navigation services over time. As you'll hear more from Gladys, this new rulemaking happened in several steps. We had the proposed rule back in July. There were comments solicited that many of you participated in developing those comments over the summer and fall. And then the final rule was just released this past November. And of course, as Elizabeth stated, we'll be going towards implementation on January 1st, 2024, meaning that the new billing codes that we're going to talk about will go live for physicians and practitioners that bill Medicare Part B in just over a month. So next slide. So what exactly does this new rule do? Well, it establishes new billing codes for a spectrum of services, including some related to patient navigation. These services may be billed when they're reasonable and necessary to diagnose or treat the patient. This slide briefly summarizes those relevant services and the codes that a Medicare provider would use to seek payment. In the rules, CMS noted that it created actually 3 new buckets of codes that respond in some way to health-related social needs. These included principal illness navigation, community health integration services, which is a category very relevant to, for example, community health workers, and social determinants of health risk assessment. I list all of these services here as I think all of them could be relevant to providing high quality cancer care and to patient navigation in particular. However, given our limited time today, I'm going to focus particularly on the new codes most specific to oncology patient navigation, and that's the new principal illness navigation services codes. However, if you're interested in learning more about all 3 of the categories on this slide, I recommend taking a look at our center summary that's available on the NNRT website and on the URL you see at the bottom of this page. I'll also note that the physician fee schedule rule is an enormous rule. It's about 1,000 pages long. There are a lot of other interesting changes that occur under this rule, some of which could be relevant to specific segments of the navigation field. For example, the new rule also newly recognizes clinical social workers' ability to bill for important services such as health behavior assessment and intervention services. And so we know that there are other groups that are following those changes as well that could give you more information there, such as the Center for Health and Social Integration. But given our limited time today, we're going to focus specifically again, on principal illness navigation. But I do want to flag right off the bat as we'll talk about at the end of this webinar, although NNRT is focusing today in on these PIN services, we're also actively considering what steps we can take to support patient navigation programs with these new changes. And so if there are other changes you think should be highlighted in those follow-up activities, don't hesitate to share that with NNRT leaders so we can consider how to incorporate them into sort of technical assistance moving forward. So next slide. And next slide. So let's now take a deep dive into principal illness navigation specifically. First, let's look at the 3 core elements of this new rule. First, who is eligible to receive PIN services, which I'll use as the sort of shorter acronym for now, what PIN services can look like, and then who can deliver them. I'll walk through each of these at a high level, starting with who may receive these principal illness navigation services. To be eligible to receive these services, the patient must be enrolled in Medicare. So remember, we're in the Medicare program here. And second, have a serious high-risk condition. CMS defines a serious high-risk condition as one that is expected to last at least 3 months, that places the patient at significant risk of hospitalization, nursing home placement, acute exacerbation or decomposition, functional decline, or death, that requires a disease-specific care plan and may require frequent adjustment in medication or treatment regimen or substantial assistance from a caregiver. So this is a bit of a complicated standard, but CMS helpfully provides some examples of the types of conditions that could qualify. For example, CMS states that cancer, COPD, congestive heart failure, dementia, HIV/AIDS, severe mental illness, and substance use disorder could all qualify as a serious high-risk condition. Notably, CMS also recognized that providers may identify a serious high-risk condition weeks or months before a definitive diagnosis is actually reached. And so CMS acknowledges that we don't require a specific diagnosis before a practitioner can determine that a patient qualifies for these PIN services. So they can acknowledge that there is a serious high-risk condition before perhaps an exact diagnosis is reached. And you don't have to wait until you reach that diagnosis to provide these services. Next, the rule lays out next slide. Next, the rule lays out what PIN services can look like. The rule describes the scope of the services broadly, outlining 9 categories of services that would be eligible for reimbursement as part of principal illness navigation. Those categories are summarized here on this slide and include things like person-centered assessment, health education, healthcare access, and health system navigation, among other things. Next slide. And third, the rule outlines who may provide these services. The rule states that PIN services may be provided by certified or trained auxiliary personnel under the direction of a physician or other practitioner, including a patient navigator or certified peer specialist. So let's unpack that a little bit, because there are a couple of key points built into that statement. First, importantly, CMS explicitly recognizes that these PIN services may be provided by auxiliary personnel, which CMS states includes patient navigators. So that's, the main takeaway here from this slide, that patient navigators can provide PIN services, and that's the big news here. Second, CMS states that PIN services must be provided under the direction, so defined here as general supervision, of a physician or practitioner. This means that the patient navigator who provides the PIN services must be under the overall direction and control of a physician or practitioner, but that the practitioner does not need to be physically present while the navigator provides the services. And furthermore, again, showing sort of the flexibility of this rule, these patient navigators don't even necessarily have to be directly on staff at the practitioner's organization. A physician or practitioner may contract with an outside entity like a community-based organization to provide PIN services. If they do so, though, they do have to make sure there is still clinical integration with those entities, meaning essentially that there must be an ongoing feedback loop between the practitioner who's billing for these services and the individuals at the CBO who are providing services. So making sure there is a line of communication about what's happening here. And so why does CMS require this supervision? Well, part of it is based on the billing mechanism that CMS is relying on here. Specifically, CMS is allowing auxiliary personnel like patient navigators to provide these principal illness navigation services through what's called incident to billing. Incident to billing occurs when a Medicare enrolled provider, such as a physician or a nurse practitioner, initiates a patient's care and develops a treatment plan, and then auxiliary personnel provide follow-up services as part of the implementation of that plan under the supervision of that original provider. Medicare allows the original provider who developed the plan to bill for those follow-up services as part of what's called incident to billing. And that's a really key component of what CMS is doing here, leveraging the idea of incident to billing to provide flexibility in who's actually delivering principal illness navigation services. And finally, I think the other important point in this statement from the rule is that individuals providing principal illness navigation services must be certified or trained. So next slide. And again, CMS is broad in defining what it means by certified or trained here. CMS acknowledges that some states have specific certification or licensure programs for the types of auxiliary personnel that might provide these services, like patient navigators. In those states, auxiliary personnel must meet state requirements in order to be able to deliver these services. However, CMS also recognizes that many states still lack specific certification programs or requirements for these roles. In those states, CMS says that individuals providing principal illness navigation services must simply be trained to deliver all the service elements, so those categories of services on our earlier slide, and that training must include certain core competencies which are described on this slide. The one exception to this broad, flexible approach is principal illness navigation peer support services, which is a new category that got added under the final rule. If no certification exists for peer supports in a given state, CMS is requiring training to be consistent with the national model standards for peer support certification published by SAMHSA. So next slide. In addition to establishing who may receive services, what services have to look like, and who may provide them, the final rule also provides important information about the process of actually delivering these services. The key elements of that process are outlined on this slide. And I'll note here that CMS has applied a very similar process for those community health integration services, which are a little different from PIN services and really aim to address social determinants of health. So while I'm focusing on principal illness navigation, I just wanted to note that many of the same points that I'm making here about these services apply there, and I'll talk about that a little bit at the end of my presentation. So let's walk through this process step by step, starting with the initiating visit. So next slide. Before principal illness navigation services can begin or be billed, there must be an initiating visit with the patient. This visit needs to be conducted by the physician or practitioner who will be billing for the principal illness navigation services. Again, this is part of that incident to concept. So there must be an initial visit with that billing physician or practitioner. The goal of the initiating visit is really to establish a treatment plan, specify how principal illness navigation services would help to accomplish that plan, and establish that the principal illness navigation services as incident to the billing practitioner service. In the final rule, CMS outlines 3 specific sort of types of visits that can qualify as an initiating visit for PIN services. First, evaluation and management visits, other than those provided by a low-level visit, other than low-level visits performed by clinical staff. Again, you have to have this performed by a physician or practitioner who is able to use incident to billing. Second, an annual wellness visit when furnished by a practitioner who identified in that wellness visit a high-risk condition that would qualify for these navigation services. And third, 2 types of visits that play a similar evaluation and management role for clinical psychologists. So psychiatric diagnostic evaluation and visits involving health behavior assessment and intervention services. Notably, this initiating visit doesn't have to occur every month that services are received. It just has to occur once before starting the provision of these navigation services, and then must be repeated once each year. So next slide. In addition to conducting an initiating visit, before providing services, you must also obtain patient consent to deliver the principal illness navigation services. Again, there is flexibility on how this happens. The consent can be obtained by the auxiliary personnel, so the navigator. It can be written or verbal. The consent just must be documented in the patient medical record, and it must explain that there is cost sharing associated with these navigation services. Similar to the initiating visit, the consent does not have to happen every time services are provided. It just has to happen once before beginning delivery of principal illness navigation services, and then reobtained on an annual basis. Next slide. Once consent is obtained, the auxiliary personnel can provide the principal illness navigation services to address the patient's needs in accordance with that treatment plan that was developed in the initiating visit. As a reminder, these services fall into 9 broad categories that are outlined on this slide. Next slide. Once the services have been provided, they must then be documented in the medical record. Notably, while the services themselves can be provided by those auxiliary personnel, it is the billing physician or practitioner who's ultimately responsible for the documentation. Specifically, that practitioner has to make sure there's documentation of things like the time spent providing these navigation services, the activities performed, how they related to the treatment plan, and social determinant of health needs that were identified as part of this process, if any. Next slide. And then finally, the billing physician or practitioner must bill for the services. Again, this billing practitioner accounts for the time spent by auxiliary personnel by using that incident to approach for their services. So to do so, the physician or practitioner will use the new codes that are outlined in the physician fee schedule rule. These codes are summarized on this slide. So for example, if a patient navigator provides 2 hours of patient principal illness navigation services for a patient in a given month, the billing practitioner would start by using G0023 to account for that first hour. And then there is G0024, which is the add-on code that allows for additional time beyond that initial 60 minutes and can be billed repeatedly to account for sort of additional time used. So they would bill, again, for 2 hours, right? So you would have G0023 for the first hour, and then 2 times billing G0024 for those additional 2 half hours. And notably, the rule does not set any limits on the number of times that add-on code can be billed. The billing practitioner would take a similar approach for some of the other codes listed here. If, for example, if it was specifically peer supports, they would bill G0140 for the first hour, and then G0146 for each additional 30-minute increment after that. And then I do want to note sort of one wrinkle here. Notably, physicians and practitioners in FQHCs or rural health centers would use a different approach. Their CMS expanded the scope of G0511, a code used for general care management, allowing FQHCs and rural health centers to bill separately for this service and allowing them to bill multiple times for it in a given month, as long as the requirements are met each time. Finally, I think it's important to note that the rule does not necessarily place any practitioner limit on these services. CMS acknowledges that it is feasible for people to be enrolled in and receiving principal illness navigation services for multiple places at one time. For example, if they're navigating multiple conditions with different clinics or centers, and therefore CMS allows multiple practitioners to bill, although CMS expects this approach to be limited in practice. And next slide, final slide here. As I mentioned, we know there are definitely other codes in the physician fee schedule that would be relevant and helpful to supporting patient navigation activities. Some of these are those listed on the first slide. So social determinant of health risk assessment code, changes to things like the health behavior assessment and intervention services, and the new codes regarding community health integration. While I don't have time to go into each of these codes in depth today, I did just want to briefly flag a few of the ways that community health integration, CHI services in particular, overlap or differ from principal illness navigation services, as these CHI services have particular importance to community health worker community, which overlaps with and is a critical part of the patient navigation community. Notably, much of what I've just said about principal illness navigation services applies to CHI services as well, as CMS has largely taken a parallel approach to these two categories of services. And so I just want to take a moment to flag a couple of ways in which they might differ. First, the main difference between principal illness navigation and these community health integration services is around eligibility. So who these services are designed to reach. As you'll remember, to be eligible for principal illness navigation services, Medicare patients have to have that serious high-risk condition. In contrast, Medicare enrollees do not have to have a serious high-risk condition to receive PHI services. Instead, they simply have to have a social determinant of health need, such as food insecurity, transportation insecurity, or housing instability, that is significantly limiting the Medicare practitioner's ability to diagnose or treat their medical condition. This focus on social determinants of health is then really the defining feature of these CHI services, and in many of the differences between CHI services and principal illness navigation. For example, like principal illness navigation, CMS describes the scope of CHI services as falling within 8 broad categories that generally overlap with those same categories of PIN services, including things like person-centered assessment, practitioner, home and community-based care coordination, and health education. However, in each of those categories, there tends to be a specific attention to addressing the identified social determinant of health need, right? In contrast, CMS acknowledges that addressing social determinants of health may be a part of principal illness navigation, but also may not be, depending on the needs of that individual patient. And then, like principal illness navigation services, CHI services can be provided by auxiliary personnel under general supervision of a billing physician or Medicare practitioner using that incident to approach. Additionally, CMS once again notes that the auxiliary personnel do not have to be on staff at the practitioner's organization. The organization can contract with outside organizations to provide the services. But once again, there's a need for that clinical integration, right? That feedback loop between the billing practitioner and the outside organization regarding the care that's provided. And like principal illness navigation services, CMS takes a broad approach to training and certification requirements for CHI providers. Once again, in states that have certification requirements, CHI providers must meet those requirements. But where no such requirements exist, CHI providers can simply be trained on the CHI service elements and the broad core competencies identified by CMS, which again, largely overlap with those that we see for principal illness navigation. And then finally, CMS indicates that the process for providing CHI services is largely the same as providing them for principal illness navigation services. Before providing them, the billing practitioner must conduct an initiating visit and develop a treatment plan. The practitioner or auxiliary personnel must then obtain consent before providing services, and then the services must be documented and billed using the codes highlighted on this slide. Like principal illness navigation services, there's no limit on the number of times that the practitioner can bill that add-on code. However, in contrast to principal illness navigation, CMS has noted that only one practitioner may bill for CHI services in a given month. So those are just some of the distinctions and overlaps between these, as I think both of these new categories of codes could be really relevant to the patient navigation audience. And as I said, it will be providing further technical assistance in the future. So if you're interested in hearing more about these CHI services in sort of the in-depth way we've talked about principal illness navigation, please don't hesitate to let the NNRT leadership know, as we can sort of build that into planning going forward. But now I think I'm going to go ahead and pass things over to Gladys to talk a little bit more around sort of what engagement looked like around this rule, and then some other areas of our health insurance landscape.
Katie,
Thank you so much, Katie. Go ahead, Andy.
Sorry, Gladys. We're gonna pause for just a minute, Katie, because we've gotten so many questions, and so Gladys, sorry to interrupt. But we did, if you guys are okay with it, and I just want to say I want to stretch after that for Katie. I want to give Katie like kudos, either a slow clap or a standing O, because what a lot of information. And I know, Katie, as all of this is emerging, you and your team have done an amazing job of distillation of what it means, helping with the comments, helping with so many aspects of this. And so thank you. One of the I think several of the comments coming in, and I'll try to make sure to paraphrase and get as many of these in as we can, and have maybe Christina help me, because I know we have 15, 16 messages coming in. But Katie, I think one of the things that's coming forward is, if organizations don't plan on utilizing these codes, is there anything that we know that would be punitive or would stop the delivery of the navigation intervention if people plan to continue navigation but not charge through this mechanism, but maybe provide care for Medicare patients based on the CMS ruling? Anything that you've heard about obligation around utilization of codes?
So this is a great question. And one thing I'm going to note right off the bat, and I think we'll talk about this at the end again, is that one of the things we're thinking about at NRT is trying to sort of compile these questions as they come in and maybe perhaps make an FAQ document. And so I just want to flag that I do not have all the answers here today. I'm going to do my best, but I am going to reserve the right to address some of these things in that FAQ. And so if we can follow up as well. But if an organization decides to just provide patient navigation services and fund them in another way, so maybe via philanthropy or through their own organizational funding, I don't believe that there's anything in the rule that would prevent you from doing that. I think what the rule is really trying to do is just open new avenues that you could use for funding to improve the sustainability of your program. But
Okay.
Elizabeth or Gladys, if you have heard otherwise, let me know.
No, I think that's well said, Katie, and agree with that.
Agreed. Thanks, Katie.
Katie, and I think you addressed this. One of the question is, the oncology, the oncology space, is there, and I think you talked about service delivery and what codes to use in different settings. But as you describe this isn't just for oncology settings. I mean, navigation for this PIN service for community health workers, navigators can really be implemented in FQHC settings or other settings. The coding is just different. Is that just to reiterate, that's what we heard from you, correct?
Yes, the final rule does allow for that. It just notes that the coding is different in those settings. And so we can always flash that back up. But the important thing is that if you are in an FQHC or a rural health clinic, you would use G0511 instead of these other codes, just because the payment approach in those settings is slightly different. But CMS did want to account for that, and it is not limiting the number of times that can be applied.
Okay, great. And I think, we've shared with us about, what that acute PIN service really applies to. And as we understand it, Katie, right now, the provision of cancer prevention, so mammograms, colonoscopies, any prevention at this time is not included for that reimbursement. Is that correct?
So that's a really important point here, right? So this service, and I think the administration has generally acknowledged this, is sort of a starting point, these codes. And as they're framed right now, they're really targeting individuals who have a serious high-risk condition expected to last at least 3 months. And so as you can imagine, if we're really targeting an existing known condition, that it would be difficult to use these codes to get at sort of the more preventive side of things. I think CMS has acknowledged that this is a starting point, and they hope in the future to reach some of those other parts of the care spectrum. But I think that's going to be a place for advocacy moving forward.
Okay. And I know that even came out in the response that NNRT and many partners at the initial had advocated for really looking at that expansion with a big head nod to this is amazing, a great place to start. And I think I heard that in the chat, great progress. Katie, there's a ton of questions about that reimbursement and then what is the implication for patients? Do we know how much we're really seeing in terms of monetary representation with utilization of these codes? Like, is it a proportion? Is it billable hour? I know you talked about RVUs. What can we say discreetly about what we can see for compensation rates right now?
So what the rule does is it gives the RVUs, and I should just highlight that I am not a sort of coding specialist. So this is getting to the edges of my exact expertise. And I think we'll have future webinars that go into that, like implementation of the codes and what it means on the ground more specifically. So I will largely say stay tuned, but they do outline the RVUs associated with each of these. And I'm trying to pull it up so that I can just flag exactly what the RVUs were for PIN. I believe it's 1 RVU for the first hour and 0.7 for thereafter, but I just want to pull it up to make sure I'm right about that. Okay. Yeah, here. Let's see. Okay, I'm gonna pull that up and then, oh, here we go. I apologize. I have too many screens open.
Impressive, I might add.
For the principal illness navigation, in terms of RVUs, that first, remember you can bill first for 60 minutes for that first 60 minutes in a calendar month, and that's 1 RVU. And then there's an add-on code that you can use for each additional 30 minutes per calendar month, and that's 0.7 RVU.
Okay, and we can share these details as well. And so the other thing related to cost, Katie, what do we know about what this means for a patient? So for cost sharing, or what it might be for anything that is a billable code through CMS, but the patient responsibility, anything you want to say?
So I will say, I think CMS acknowledges that that was a concern it heard in the comments about cost sharing, right? There was an interest in being able to waive cost sharing, things like that. However, CMS just notes that it does not have the authority legally, sort of under the statute, to waive cost sharing for this category of services. And so the cost sharing rules for Medicare Part B will apply. And so while cost sharing waiver is of interest, it's not something CMS could do here. And so you cannot waive cost sharing. There is cost sharing applied to these services, and it's in line with the standard cost sharing under Medicare Part B.
Great. A question about auxiliary staff and what that means. So if someone is a case manager, a nurse, a medical assistant, but they have the right training, right, based on what CMS is deeming, could they provide the services?
So yes, so auxiliary staff can provide these services, and that's sort of broad in what that staff is, and it can include patient navigators. CMS is trying to be very flexible here. The important thing to remember is that we're operating within that incident to framework. So you have to have somebody who is a billing practitioner, so a physician or a non-physician practitioner who legally has the ability to bill incident to. And so they have to do the initiating visit and develop the care plan, and then the auxiliary staff can then essentially implement and bill, and that initial practitioner then sort of incorporates their work in their own billing, and they incorporate that as incident to services.
Okay. And Katie, there's a few other.
I'm just going to flag that's another kind of complicated thing that I feel like we can also dig into more when we go into those sort of practical implementation TA sessions in the future.
Okay. And I think there were some specific questions circling back to the money and the cost sharing about, is the cost sharing different for like Medicare Advantage versus different plans, and what are the nuances based? Anything that you want to say relative to that based on your previous answer?
I don't think so specifically. I mean, we can dig more into that perhaps in detail in the FAQs, but I think the big takeaway message here is that CMS, just based on the legal framework in which it's operating, could not waive cost sharing, and so normal cost sharing rules apply here. Okay,
as it relates to what it typically does through it. Okay. So, and then I think the question is coming out particularly around nurse navigators. So RNs, LPNs, and Katie, if you want to reiterate, I think that's the group of folks, if they're considered auxiliary folks as the definition through CMS, and what we know about that.
Sure, just one second. I'm just pulling up my list here. So yes, so most of those roles would be auxiliary, right? It's and the biller, though, then the sort of overarching biller has to be somebody who has the ability to bill incident to, which are physicians and certain non-physician practitioners. And happy to go into more detail on that in follow-up too. If it's
okay.
helpful.
And I did see a question specifically about incident, and it came from a good and dear colleague and friend of mine in Colorado. So I was trying to make sure. And then, so Katie, one of the questions, I'll go back to the incident, but I think to this whole idea of role and thinking, the questions come up that some of the services are ones that are under also the scope of practice of a licensed social worker or nurses, right? So, we're talking about who gets to under the incident of care and the billing provider, but then also really thinking about that role clarification. And I think the question is speaking to, who is doing what within practice, and that distinction of the navigation versus the rest of the care team. So anything that you want to share, or any perspective from our other panelists about, people who might be delivering navigation, or what could sometimes be under scope of practice where there's overlap as it relates to this, any sort of general feedback or response?
I'm going to see Elizabeth or Gladys. Do you have thoughts on that one? In terms of scope of practice, I mean, there are elements. I think one thing I can say is that CMS acknowledges that there is some overlap here with other services that might be able to be billed in other ways, right? It's not limiting if somebody is doing similar services and it's a normal part of a different sort of billing code they would use. The creation of these new billing codes doesn't sort of foreclose, right, that practice. It just creates a new avenue that might be more effective for some types of practitioners. I think is my reaction there. But Elizabeth or Gladys, anything you would add?
What I was thinking of adding, and Andy, I apologize if this was maybe a part of your question, but or not fully, but I think you had also mentioned some kind of incident to confusion around hospital outpatient as well. And that is fair, in part because CMS has, since, kind of the final rule being kind of put out there, has acknowledged that there weren't clear instructions on sort of that hospital outpatient being able to take advantage of implementing this rule because of that incident to language, which again, as Katie said, we can kind of, in our FAQ in writing, kind of flesh that out more with everyone. But what I can say is, I think that this was more of an oversight rather than CMS trying to prohibit hospital outpatient use of these codes. Although right now, as the code is written, that is a complication that is there. So I think it's a bit of a waiting to see the agency provide, greater clarification on this piece, which we're happy to follow up with as we hear more.
Great, thank you. And Katie, I think there's some interest in maybe something we can follow up is giving people an idea of like what this cost share and what it really means for patients moving forward, so people can have a strong sense of to communicate and what that really looks like. So we can help with our partners really think. And again, this is quite new. I think we're all trying to understand some of the nuances of the billing. And again, I think still some questions coming in around the nurse role and auxiliary staff and who's, there. And so as much as we understand this, right, thinking about those provisions and getting some clarity there. So, and I think this whole idea of if someone is already a clinical licensed, trained individual, but then gone through this training, even though they're not a billable provider, will they be able to be reimbursed? And Katie, I think there's some yes, no, I'm trying to make sure. I mean, again, just a quick definitive answer for those who are just joining. Anything you want to say about that question again, because it's coming up reoccurrent around the role of RNs or social workers or LPNs who get this training about billable, whether they would be able to be CMS navigation reimbursed.
So it's broadly framed, and so I believe so. I don't see a reason why they would not be able to, as long as it fits with
my understanding.
Okay.
And
Perfect.
Katie and Andy, this is Elizabeth. I'm going to put into the chat, but just want to remind people to look at the Professional Oncology Navigation Task Force standards, because it outlines nurse navigator, social work navigator as the two clinical navigators, and then patient navigators, which falls into, we're not calling them non-clinical navigators, but they don't have a social work or nursing degree. And so those will help to provide some clarity. And we know that some of the training that you're going to see as being available to register or to get reimbursement will align with those standards. So I'm going to put that in the chat. And if anybody has any questions about that, I'm happy to answer. Okay, great. And thank you, Elizabeth, for reimbursing. And I do think, as we do think about that whole idea of role distinction and clarity, the oncology nurse and the patient oncology navigation task force, the standards, but also really thinking about that
workforce and really understanding who's doing what and being very clear about roles is something that we'll continue to support through this work as we move forward. And then Katie, this is a more granular question. For offices that use codes currently, how are we going to manage in terms of like if an office, maybe in an oncology setting, is using the billing code, but a PCP is billing for these services as well. So if we're really looking at, patient care over a variety of different settings, is there anything particularly that will be managed as it relates to this code?
So this is, I think, one of the key distinctions between principal illness and the community health integration, those more sort of social determinant focused codes, is CMS did put a specific limit on the CHI services of it being billed by essentially one practitioner per month, but we didn't see that same limit translated over to principal illness navigation. Partially in recognition that somebody may have multiple conditions that need this type of navigation. And so it's my understanding that up to this point, CMS has allowed for some of the provision of principal illness navigation by multiple practitioners in a given month, but it doesn't allow that on that CHI side.
Okay, perfect. All right. Well, and I think that a number of the questions, and we will definitely get into some of the specifics, because I think the cost sharing is relevant to different types of providers where we're still trying to see some of the nuances, really try to understand some of that. We can get back with the group. And Christina, I know you're helping me moderate the questions, and we're getting them from a couple different places. Anything that I am missing for Katie before we transition to Gladys? Katie, or I'm sorry, Christina, any other theme or anything big that we've missed for Katie?
Andy, I think that Katie has done a really fabulous job. Thank you. Thank you. My hands are folded and I'm bowing for your brilliance today, Katie. But I would say, I think we've gotten a lot of questions answered. And if we didn't answer your question specifically, as we keep saying, we will be creating an FAQ. We recognize we don't have all the answers today. This is brand new for us. So please continue to come and visit us at NNRT and at navigationroundtable.org. And we will, have additional information available.
All right. And Katie, thank you a million. We will now transition to Gladys to share a little bit about ACS CAN's work and I think some really awesome opportunities at the state level and some of the additional opportunities. So Gladys, I will turn it over to you.
Thanks, Andy. Hi, everybody. Thank you for this wonderful opportunity to really talk through what clearly, right, is a pretty complicated, although critical step in terms of increasing access to patient navigation services. So a couple of the things that I'll mention in my slide will sound or really complement things that Katie said. So I want to be thoughtful of not repeating portions of Katie's presentation, but my hope with this slide to start, so still focusing on the proposed rule for Medicare Part B. What I wanted to do was just sort of remind folks of some of the work that ACS CAN along with the Roundtable did in response to the proposed rule and how that was really a part of our advocacy and really is informing what we're doing moving forward as well. So as was talked about in great detail by Katie, this was a critical step to increase access to navigation through the reimbursement of these services under Medicare. And in response to the proposed rule during that open comment period that Elizabeth had mentioned at the beginning, we as ACS CAN, and for folks who may or may not know, we are the advocacy arm of the American Cancer Society. And as part of our advocacy work, we provide a lot of comment letters to proposed rules that mention provisions that are of priority to our organization. And that was certainly the case here, given the patient navigation or the principal illness navigation provisions of the rule. So we wrote 2 comment letters, one, both of which I can drop the links to those in the chat with everyone. We had sort of a regular letter that commented on many different things in the proposed rule, because as Katie said, the rule wasn't just about patient navigation. And so there were other priorities that we had as an organization. But we did also comment and wrote a second letter that we had as a sign-on letter that many members of the National Navigation Roundtable Roundtable joined us on. We had about 69 signatories join us, which I think really amplifies the importance of this step. And I can drop that in the chat with everyone as well. So on November 2nd, so after, the proposed rule, we commented on that. Then on November 2nd, CMS released the final rule that will be taking effect on January 1 of this coming year in 2024. Overall, as Katie sort of walked through and alluded to, we were very pleased to see that many of the things that were mentioned in the proposed rule were in fact finalized in the final rule. Although it's still kind of in draft mode, ACS will eventually be sharing for folks who are interested, sort of a compare and contrast document of what we commented on in our letters, which again, I'll share, as well as what was in the final rule. But I can talk through a couple of those on a really high level with folks. And again, we'll be thoughtful of not repeating too much of what Katie shared. So in the final rule, finalized patient consent and documentation in the medical record, which was something that we recommended. And as folks have been mentioning in their questions, was really important also to patients having a copay. Part of that consent is informing patients of possible copays that they would have to pay for as part of receiving these services. Certification and training of auxiliary personnel for providing PIN services was also finalized, which I know we've talked about a bit. So yeah, sorry, Michelle, still on this slide, the previous slide. So those were finalized, which was great. Although CMS didn't necessarily agree with us in our sign-on letter that there needed to be a specific oncology navigation training be provided, they did agree that this training that's applicable to state law and regulations is something that's important to have. And clinicians who will be the billing clinicians here will need to ensure that that requirement is met and is available in clinical records. The time and duration of these services, I know Katie mentioned sort of the 60 minutes and then the additional 30-minute services that can be provided. In our letter, we had recommended potentially increasing the frequency or breaking down kind of these time stamps. And although that was not something that was adopted into the final rule, CMS did finalize that there's no frequency limitation for the add-on code as long as the time spent is reasonable and necessary, which is really important because that means that those 30-minute codes can keep being added for that beneficiary in that month of service. CMS, one thing that we recommended that was not ultimately put into the final rule was CMS did not add PIN services on the Medicare telehealth services list. So for folks who may or may not know, this telehealth list is something that CMS manages, and part of the during the PHE or the public health emergency, during COVID, many telehealth services were added to this list given just the state of things and needing to be able to provide those services in a more flexible way. And since that health emergency has ended, some services have remained as being available through telehealth. And so although PIN services weren't added as part of this sort of final list, it'll be something that's considered in future rulemaking and an advocacy point that ACS will continue to argue for. And then also I'll mention lastly on this slide, we had also proposed that the prevention and screening portion of the continuum of care be included as covered under these PIN services, which, as was mentioned, I believe by Katie, these services are for active treatment and so do not include early detection or prevention or survivorship services as the rule is written at this time. But as I believe my colleague Christina mentioned in the chat, this is something the Biden administration has acknowledged and work that we'll continue advocating for, given that covering that prevention piece is really important. And then we can go to the next slide, Michelle. So here I'm going to shift. So that first one was me speaking to how ACS can, with the roundtable, responded to the proposed rule. And now I'm going to talk about other avenues that we're exploring, since this, although having that reimbursement under Medicare Part B is incredibly important, it's just one piece of this. And so here I listed a couple of other reimbursement pathways that ACS can, of course, in partnership with the roundtable and other member organizations, will be pushing forward in our advocacy work. So I'll start first with mentioning Medicaid reimbursement under community health workers. I think this is something that'll sound really familiar to folks. So essentially here, ACS can, with the roundtable, are looking at state policies that would provide reimbursement for community health workers, such as the recent win that we had in Colorado. And part of why this is a pathway is community health workers, their roles and responsibilities are comparable to what patient navigators do. And in some cases, right, community health workers are providing navigation services. And so we would be remiss to not look at this as a potential avenue under the Medicaid program for patient navigation services. And then I'll also mention too, and forgive me, I should have added Medicaid prior to state plan amendments, but we're also exploring Medicaid state plan amendments that would authorize whether that be targeted case management for a cancer diagnosis, or could include cancer as a chronic condition covered under different Medicaid programs. So that again could be targeted case management programs under Medicaid, or the Medicaid Health Home Program, for example. And so essentially what state plan amendments are is this is when a state is planning to make a change to its Medicaid program or operational approach. And so states send state plan amendments to CMS for their review and approval. And then states can submit these state plan amendments to request permissible program changes or make corrections or update their Medicaid or CHIP state plans to cover different things and provide services. And then lastly, I'll mention state appropriations, although we're looking at this, more specifically also in Medicaid, but this could be more general, but using state appropriated funds to provide patient navigation services. And so looking at different states that offer these. And lastly, what I'll say is you'll notice that I don't have private insurance listed here. That is in part because our hope is that private insurers tend to often follow Medicare policy. And so our hope would be that Medicare, private insurers would follow Medicare policies and implement them with private insurers. I can say that in a recent White House conversation, the administration did mention that the administration is working with the AMA around guidance around private insurance. We don't know exactly what that would look like, but that's certainly something that we are tracking and look forward to kind of getting more information about that, what that'll ultimately look like. But lastly, I'll just end by saying, with the visual underneath on this slide, parts of why, we're looking at Medicare and private insurance and Medicaid state options is because we really wanted to cover the whole continuum. And we recognize that it might need to be a bit of a patchwork to get us started. That state plan amendments, for example, could cover prevention and early detection, but then the Medicare physician fee schedule could cover diagnosis and treatment, for instance. So we recognize that there won't be one solution to covering the continuum. And so we want to think about how all these pieces can fit together to provide access for all patients, whether that be from prevention all the way to survivorship. So I'll pause there in case there are any questions. And Andy, happy to hand it over to you.
Awesome. So I want to circle back, Gladys and Katie and Elizabeth, because I do think there's a question that came up in the chat previous that I think it really kind of comes to the idea about the ruling, right, in the physician fee schedule, and that this is updated annually, right? So there was a question to say, and I think it's a good question to say, if CMS sees strong implementation of these codes being utilized, would that be something that would probably be a bit of a moniker, right? That it should really be utilized more expansively to prevention services, other services. Is there a sense from all of you that if CMS sees these codes really being implemented and people really rallying around this, that there's probably a stronger opportunity for expansion, maybe stronger reimbursement? What's your sense? I know you don't have a crystal ball and I know you're not CMS, but what's your general sense of does it bode well? Does it make a difference? What do you guys think?
This is Elizabeth. I thought that that was a fantastic question. And I'm just going to, like you said, Andy, look into my crystal ball, which has never worked. So everybody take this with a grain of salt. But, you know, I think part of the reason why these codes were created is because of the incredible advocacy by the folks on this call today, right? By all of the navigators, by the NNRT, by the organizations, AONN and others, to prove not only why patient navigation is the right thing to do, right? We know this. We know that navigation is the right, humane thing to do. But we've also done a really good job, and the NNRT cancer supplement papers proved this, to show that navigation is not only the right thing to do, but it also actually saves the system money, right? That it can prevent rehospitalizations, that it can prevent unnecessarily or inappropriate utilization of services. And so it's not just the uptake of this code, it's also the entire sort of context. So the reason that I bring that up is because it's a complicated picture. It's not sort of just that a code's going to be used, they see that it's useful and people need it. It's more the entire picture. And so I think when it comes to prevention and screening, continuing to talk about the fact that navigators save the system money, that they improve outcomes, you know, all of these things. So I think it's going to take a more robust advocacy campaign around screening and prevention to prove the case, and not just that we are going to use these codes. But I think it's a fantastic point to show that if these codes are implemented, that they are used because they're really important. So that's my kind of gut feeling, but I'm curious what Gladys and Katie think.
I'll just echo Elizabeth. I think your comments are spot on, and I think that is a great question, and certainly something that we're happy to kind of share more as we learn more and things that we hear from the agency or others close to this. And I think what I'll also say too, that question made me think of, even in the proposed rule language itself, even the creation of sort of proposing that these codes that were ultimately adopted, CMS acknowledged the value of navigation services in saying, what I took that to mean was, oh, we're thinking of actually having these codes be created because it's been shown that these services are worthy of being reimbursed in that way. And so I think that the more that kind of, as Elizabeth said, that return on investment, those savings to the health system, I think it'll just further show the work that still needs to be done as it relates to these services and these codes covering even more parts of what these services can ultimately provide. And the administration even acknowledging that, you know, without it being a question, just sort of on their own accord, mentioning the need for prevention and service and screening to be a part of this, I also took as a really good sign of understanding the value of these services, and that won't go away moving forward.
Yes, perfect. And Christina has reminded me that we are actually over, but I will take this one other question, because I do think there was a question specifically about the telehealth visit, and I think we've since PIN services are not included on the telehealth service list, would this exclude any work being done by a telephone? And I think my question got cut off there, but in terms of the exclusion there in telehealth, what are the provisions? I mean, are there any latitude for telehealth visits at all within the PIN service and with the work with CMS?
I'm going to take a look at my summary that I have. So apologies, folks, for the telehealth list.
Perfect. And Gladys, while you're doing that, one thing I want to also just share is, like, being part of the Colorado experience, you know, one of the things that I think based on the CHW work and, you know, using that, you know, I think the global discussion was using the moniker community health workers, but to include navigators, promotores, and through a stakeholder process, really delineating, you know, those functions and roles as it relates to the delivery and types of service. So, you know, one of the things I think is interesting is we do see, I think, a difference in role and role clarity as it relates to the standards, SCHWs and the like. But I do find it interesting right now that I do think a number of our policymakers, as well as people who are really looking at legislative as well as other initiatives, are really sort of seeming to gravitate to global terms to give most opportunity, knowing that through, you know, the processes for implementation that we can work out some of these pieces. So in Colorado, I think we're going to be implementing this. Other states are. I would invite everyone to, you know, look into these to really think about what that looks like. And I know ACS Han is going to be a great leader in learning along with us, as well as taking the best practices and probably cautionary tales of what to do and not to do in the future. But I did want to make that piece. But Gladys, I know you're dusting off your notes there really quickly. So, and then I would say, as we're doing this really quickly, I would be remiss to not mention the evaluation that Michelle had mentioned. We really need to hear your discussion and the post-evaluation. But Gladys, I'll let you answer that final question, and then I'm going to turn it over to Michelle for any final pieces of info since we are running over time. So Gladys.
Thanks, Andy. And what I'll do too is I do want to double confirm with folks around the telephone portion, because what I can say is, yes, I know that PIN services on the Medicare telehealth list weren't ultimately adopted, but CMS did seek comments on in-person audio only and two-way audio. And so I just want to double confirm that the telehealth piece isn't just for, whether it's just for video, and if that also includes just audio only services. So I apologize. I just don't want to make sure I get that wrong. So if that's okay with folks, I think that'll be part of sort of the package, Andy, that we ultimately put together for folks afterwards as we learn more.
Yes, exactly. Okay, Michelle, in terms of any sort of call to action, Slido, post-evaluation, anything else to share with the group before we close today?
So as Andy mentioned, we have one more Slido or polling question, which is now up on your screen. Again, you can use your smartphone and hover your camera over the QR code to participate in this Slido polling question, or you can go to slido.com, type in 3025645 on your screen to actively participate in this polling question. This will also, with this polling question, you can certainly select more than one, but definitely please, put forward your top two. This is also on the post-evaluation written form. So again, if you do find that you have additional needs, you can certainly include that in the post-evaluation written form as well. Looks like the FAQs as well as the implementation of the PIN codes seem to be the most popular, but we'll certainly also address all of the areas that are currently being populated on the screen. Andy, do you see any other?
No, I just want to say a huge thank
Notation?
you. Yeah. And as mentioned at the outset, we will be continuing to look at opportunities to provide, I think as Elizabeth said at the beginning, this is not, a one and done conversation. I think we plan to help promote the work of partners who will be doing further areas of exploration and discussion as it's relevant to the work. NNRT will be helping with some of the areas where, we can help support. We need to hear from you, I think, about what those are. We'd like to partner with organizations who may be implementing and thinking about this work together. And, the ideas, I think synergy, collaboration, I think that came through today. And again, a huge thank you to our sponsors and Gladys, Elizabeth, Katie, amazing job. And really appreciate all of the leadership of the American Cancer Society, Christina, Michelle, Linda, and also Jen, and all of you who sit on our task groups and membership. So follow along, more to come, and super excited to share, I think, the details. I just can't wait. So have a great afternoon, everyone. I think it's afternoon for everybody almost now on every coast. So have a good one. Thank you all. Enjoy your evening. Bye-bye.